Hey guys, welcome back once again. Am I audible and am I visible? If so, say me a hi and a hello. So we are in the second series of the exam paper writing. So this time I have made the entire two essay questions using artificial intelligence, and I'll tell you in the group how to do it, right? So the biggest thing what we struggle is always about presentation. That's what the series also is going to target. Hello, good evening, Siddhi. Hope you're doing good. So I have two essay questions, like I said in the WhatsApp group, and also I have added 5 reasoning why questions, how to write and how to present the answer. Because reasoning why is something which came new for your batch in the first year. I hope that will replicate in second year as well, right? So we're ready. Let's start it. Good evening, Arya. Good evening, Siddhi. Fine. So the first question, I want you guys to comment on the right answer. Then we'll go to the explanation of the subtype. So I will zoom in only to the question so that you can see only the question and tell me what's the right answer without getting any of the clues from the other part, right? So this is a question. It's a very simple question. I want you to tell the right answer first. What is the diagnosis in the long answer question? Then also I want a little bit of help from you. How will you structure it? Because in the last video, last class, what we saw is how to write the data and how to present it so that it look like you really thought through the case. Can anyone tell me what's the answer? I'm sure most of you will tell the right answer because we know the keywords, right? With the keywords, we'll be able to clearly tell the right answer. I think one of the important keywords here is the Rouleaux formation, punched out light lesion, right? Good evening, Utkarsh. Good evening, Sarkar. Can anyone tell me what's the right answer? Come on, it's a very simple question. 64-year-old male present with a severe backache, progressive fatigue, recurrent respiratory infections, serum calcium is 11.5, elevated blood urea nitrogen, creatinine, peripheral smear demonstrates a Rouleaux formation for erythrocytes, and skull shows punched out light lesion. No takers? I want takers. I want you guys to tell the right answer. Then only I'm even going to show the question. Come on, Siddhi, Arya, Sarkar, Utkarsh, and many more people who are watching silently. What's the right answer? It's okay if you're wrong. It's a question from WBC disorders. I'll also give you a hint, but I want the right answer. Could it be a leukemia? Could it be a lymphoma? I'll give you 4 options: leukemia, lymphoma, myeloma, infection. If you're not going to say after the 4 options, it's very, very tough. It's a simple answer, right? All the findings here are very, very characteristic of multiple myeloma, right? Okay, let's zoom in and we'll see, look at the keywords first, then we'll go to the other part. Sarkar, why Thal minor? Thal minor in a 64-year-old person? Unlikely, right? It's not possible. See, every time you have to look into the history, you have to look into the age, then come to the diagnosis, right? Dr. Santosh sir, you are not allowed here to answer here, right? So it's a classical and simple case of multiple myeloma, right? So let's underline the keywords. 64-year-old, definitely. And these are the characteristic feature where myeloma presents with, right? And like Santosh has said, the CRAP criteria, right? The hypercalcemia, renal problem, anemia, and also the bony light lesion. All of them are there. That points to only one thing, myeloma. So like I said in the previous class, the goal is not only to get the right diagnosis, also to tell how to present the exam, right? Sometimes you might not get the right diagnosis just by reading the question. But when you start writing the same pointers, it can easily give a good answer, right? Again, it's a case summary. 64-year-old person presenting with a low backache, progressive fatigue, and respiratory infections. Very easy way to start an essay question, and it will be good also. You are redoing the entire thing, what the question is given, and you also are presenting serum calcium 11.5 is elevated, 9 to 11 milligram percentage is the normal one, 11.5 is elevated, blood urea nitrogen elevated, creatinine elevated. We can also write indicating renal failure here. Okay. And peripheral smear shows Rouleaux formation, right? Just not related to this. Sure, Gutta, Achintya, you can do it. Fine. Not related to this, a simple question. Can anyone tell me what is the reason for Rouleaux formation in case of a multiple myeloma? That could be a reasoning why question. I'll come to the answer soon, right? Rouleaux formation is there, and skull radiography shows multiple lytic lesion. Here, you can write bony lesions. So once you present the same history in a form of a data sheet or a case summary, it will help you. Yes, we are going to talk about the CRAP criteria. A information is not given, right? The CRAP criteria, right? So with the CRAP criteria and an elderly person, the most probable diagnosis is myeloma. The wordings are very important, right? The most probable diagnosis will be multiple myeloma. I don't want you to give here differential diagnosis because differential diagnosis is not worthwhile here. You have to write the right diagnosis here. Fine. Okay. Now I asked you a question. Can anyone tell me why is there a Rouleaux formation in case of a multiple myeloma? Any idea? This definitely could be a reasoning why. Can come in an MCQ in your NEET PG INACT or even in your exam. Why is there Rouleaux formation in multiple myeloma, right? So just I'm writing it here. Rouleaux formation in multiple myeloma, something is very important. Okay. So in multiple myeloma, the tumor cells, the proliferation of the tumor cells, great, Siddhi, right? It's about the interleukin 6. Interleukin 6 is one of the important reason why the neoplastic plasma cells keeps on dividing, right? Or other words, interleukin 6 is one of the, I would say indirectly, the growth driver for the neoplasm for multiple myeloma, right? So interleukin 6 is also an acute phase reactant if you remember. So it increases fibrinogen levels in the blood. The moment fibrinogen levels in the blood increase, you all obviously know the zeta potential gets neutralized between the RBCs. This will result in, like Siddhi exactly said, the faster settling of blood of RBCs. And that increases your two things. It increases your ESR. Elevated ESR is very, very classical for myeloma, though it is not something which is used these days. We have much more defined criteria. Not just that, it will also increase the sedimentation of RBC in the peripheral smear, which is Rouleaux. Rouleaux is nothing but stack of coins. RBC is settling on one on top of the other, right? This could be a reasoning by question. Multiple myeloma, one of the growth drivers is interleukin 6. Interleukin 6 has multiple other roles that results in Rouleaux formation, right? A Viva question. So, is Rouleaux formation specific for myeloma or is it not a specific finding? What do you guys will say? If I'm the examiner, I'm going to ask you, you found Rouleaux, is it specific for myeloma? Can I confirm myeloma with Rouleaux formation? Yes, no, maybe. 3 options. Yes, no, maybe. Just answer that. You might be right, you might be wrong, doesn't matter at all for us. Can we tell? No, definitely not. Infection also will increase interleukin 6. For example, pregnancy itself can increase fibrinogen levels. So Rouleaux can be seen in pregnant women, Rouleaux can be seen in sepsis patient, Rouleaux can be seen in infections, and also can be seen in case of multiple myeloma. It's a very, very non-specific finding. You cannot use it for diagnosis, right? Perfect. So now we know how to write the diagnosis. Now let's go back to the original question. We'll see what are the other subdivisions there. Define, establish the clinical diagnosis. We have already done that. And write about the core diagnostic criteria, CRAP criteria. Okay. See, CRAP criteria everyone knows. CRAP criteria is the only thing which is asked here. But I would urge you to also write the other criteria of multiple myeloma. Can anyone tell me what is the other criteria, which is the only one which is used? CRAP is very, very old. This criteria is laying down for past 10 years. There's one more criteria which starts with S. SLIM, SLIM, or the biomarkers of malignancy is more important than the CRAP criteria. Though the question talked about CRAP criteria, write CRAP criteria, we like to show off, right? In addition, write SLIM criteria also. If the time permits, do that. If the time doesn't permit, ignore it. Fine. Everything is based on the exam scenario, not based on here, right? Okay. So we have two criteria, CRAP as well as SLIM for multiple myeloma. You know CRAP, hypercalcemia, C, more than 11 milligram per deciliter percentage is more for hypercalcemia. 9 to 11 is normal. Anything more than 11 is abnormal. Renal impairment more than 2 milligram percentage for multiple myeloma. I'm going to call it an A of the R of the CRAP criteria, right? A, hemoglobin less than 10 gram if I don't have a previous value. If you have a previous value, more than 2% reduction. For example, my normal hemoglobin is 14. Anything less than 12 is branded as anemia in case of CRAP criteria. And B, the most important thing is it should be on a CT scan. Sorry, it should be on an X-ray. If you see bony lytic lesion on a skeletal radiograph, I'm going to call it a CRAP criteria, right? And the best one is not CRAP. Can anyone tell me why CRAP was replaced? Reasoning why questions. We always need reasoning why questions, right? CRAP signifies, as the name says, end organ damage. We were at a moment that only when the end organ got damaged, we'll go and diagnose myeloma. That is wrong, right? What is the fun in giving the therapy when kidney is gone, bone marrow is gone? I have to diagnose it before that. That's why CRAP became obsolete, because with CRAP, I was able to diagnose multiple myeloma or brand them as multiple myeloma only after the end organ damage. That's where SLIM came. SLIM is myeloma defining events or the biomarkers of malignancy, right? SLIM, it's S for 60, more than or equal to 60% clonal plasma cells in the bone marrow, not in the peripheral smear. It's actually Li for the light chain ratio, involved to the uninvolved. Li stands for the light chain ratio. FLC, nothing but free light chain, that's all, right? It's light chain ratio, and this is M, fine. Okay, more than 100, the ratio involved to uninvolved, which means involved light chain, that's kappa or lambda, is 100 times more than the uninvolved. So it cannot be infection, cannot be inflammation, can only be neoplastic. Then yes, I'll think of a multiple myeloma. And M for more than one MRI's focal lesion, right? And at least it should be 5 mm in size. If you can write this, write this. Otherwise, just limit with more than one focal lesion in MRI. That is diagnostic of a multiple myeloma, right? Okay, perfect. So here, any one of them is enough for me to call it a myeloma. That's why we also use the term, this is also called as an biomarkers of malignancy in case of multiple myeloma. I'm not going to use it for any other malignancy, only for multiple myeloma, I'm going to use this, right? So SLIM, myeloma defining events or biomarkers of malignancy, more than 60 percentage bone marrow plasma cells, light chain ratio of more than 100, which means 100 times one is more than the other, and focal MRI lesions. MRI lesion is nothing but this is equivalent to the bone marrow's stromal damage. Because what we saw in the Crab criteria was the bone has to get damaged. I don't wait till that moment. Even if the stroma is getting damaged, there'll be lesion there, which can be picked on MRI. That is going to be for SLIM criteria, right? So the second half of the first question, we know what's the diagnosis, and we also know how did we come to the diagnosis, right? So now let's go to the next half of the question. Discuss the bone marrow aspirate biopsy finding and detailing the classical cytomorphology of the abnormal cells. Before even going to this, can anyone name a few cells, named cells in case of multiple myeloma? Whatever comes to your mind. Any few named cells in case of a multiple myeloma? Any few named cells? Whatever comes to your mind. You know many cells, any one named or few named cells in multiple myeloma, okay? You're hesitating, let's go through it. See, the most important thing is bone marrow findings, all the named cells are great, but the diagnosis of multiple myeloma is not based on the presence of Mott cells or Dutcher cells or Russell bodies, not like that at all. The diagnosis is always based on the number. More than or equal to 10 is enough for me. It could be 10, it could be 11, it could be 20, it could be 80, it could be 90 also, right? So here, if you look at the bone marrow findings, what is more important for me is anything more than or equal to 10 is enough. In SLIM, we saw more than or equal to 60. But by definition, anything more than or equal to 10 clonal plasma cell is almost diagnostic of a multiple myeloma. More than or equal to 10 is a standard for me, right? So I should have an hypercellular bone marrow. Keep this in mind. Write this in a separate place. Whenever a question is asked on any leukemia or any hematolymphoid neoplasm, you can, without thinking, you can write hypercellular bone marrow. They will not ask, even if they ask you any hemolytic anemia, because hemolytic anemia, I don't do a bone marrow at all. But there's a possibility they will ask you the bone marrow findings of thalassemia. Never done, but theoretically they might ask you. Any hemolytic anemia, bone marrow will be hypercellular because lysis happens, bone marrow proliferates. Got it? So hypercellular bone marrow can be the first finding for any of the leukemia, hematolymphoid neoplasms, any hemolytic anemia. 1 point we already got, right? And I have increase in bone marrow plasma cells. And again, this also is a finding which you can write significantly used in many other places. Suppression of the background trilineage hematopoiesis. We can write trilineage or just write suppression of background hematopoiesis. What does it mean? If I have an acute myeloid leukemia, RBCs and platelets will be suppressed. Again, a point where I can generalize the statement. If I have an acute myeloid leukemia, again, everything else will be suppressed. If I have a hemolytic anemia, erythroid will be more. Other two might be suppressed. In case of thalassemia, very severe. There's a possibility, right? So in case of leukemias, And hematolymphoid neoplasms again use this. Suppression of normal hematopoiesis is happening, right? This is just a gist on how to present the answer. That's it, fine. Then we'll come to the classical cytomorphology. You know how to describe a plasma cell. Never go without describing the normal. You'll have cytomorphology of normal plasma cell. You'll have the eccentric oval cell with an eccentric nuclei, clock-faced chromatin. You have a pink cytoplasm, and the most important thing everyone knows, that is a perinuclear half or the perinuclear halo. Very simple. Try to mark like what is shown in the image, every single thing, right? So I can even have normal plasma cells. It doesn't matter for me. If I see a normal plasma cell of 12, 13, 14%, still I'm going to suspect myeloma. It's not always the MOT cell. It's not always the Dutcher body. Even normal is okay for me, right? I can have normal. I can have binucleate. I can have trinucleate, right? 2 nucleus, 3 nucleus. All these are abnormal. I can have 2 nucleus and 3 nucleus. Then, like Siddhi said, I can have MOT cell, berry-like, intracytoplasmic, intranuclear inclusions. You have forgotten that, right? I can have binucleation. I can have multiple nucleation. I can have prominent nucleoli, right? MOT cell, these are the grape-like vesicles. You must have seen MOT cells in a lecture. So we have a plasma cell here. I'll have multiple berry-like, grape-like vesicles. That's MOT cell, right? At the same time, you might have plasma blast. These are very much immature. In addition to that, we had Dutcher bodies. Can anyone recollect what is Dutcher body and what is Russell bodies? Can anyone recollect that? What is Dutcher body and what is Russell bodies? Yes, no, maybe. Dutcher is, you'll have intranuclear inclusion. If it's possible, draw a diagram. Otherwise, just write intranuclear inclusion. Russell body, intracytoplasmic inclusions. So this also is possible, right? I can have Dutcher body, Russell bodies, and all the variations of plasma cells, right? Simple way. If you can write one line, draw a diagram like this, enough. Need not be beautiful diagrams, need to be representative diagrams. Please understand that, right? So I can have all these atypical finding or even a normal plasma cell, but the only thing required for me is more than 10%. The percentage is more important than others, fine? For which you are asking, Siddhi. If you're asking for a leukemia, if CBC is normal or abnormal, doesn't matter for me. Bone marrow will be hypercellular. See, because there are stages. Bone marrow is where the cancer starts for a leukemia, right? So if it's starting, let's say for example, now, after 1 year, it might not come in the peripheral smear. It will be stuck in the bone marrow only. Maybe after 1.5 years, it might come outside. The number I'm giving is arbitrary, but here it starts here, it stays here, it fills here, then only comes to the peripheral blood. This is true for every hematolymphoid neoplasm, which is going to originate from the bone marrow. So even if the CBC is normal, bone marrow will be hypercellular because that's where the neoplasm starts. Only when it fills there, it comes outside and reflects in the CBC. Fine? Done. Perfect. So this is the answer for the second subdivision, the morphological, cytomorphological features of multiple myeloma. Let's go next thing. Again, I want you to tell what you think of, then I'll complete it. Can anyone tell me the answer for this? Discuss the pathogenesis of renal failure in this patient. You know, everyone knows that kidney will be affected in case of myeloma. That's one of the CRAP criteria as well, right? Can anyone tell me any one mechanism? 1 or 2 words is enough for us to build a beautiful story. But that 1 or 2 keywords should be very strong and solid. Anything which comes to your mind. Anything. Okay, let's see. Fine. So for myeloma kidney and myeloma in the renal involvement, there are 3 things which are important. One is myeloma kidney itself is an entity and light chain mediated injury. Do you remember your Benz-Jones proteinuria in your first year? That's nothing but light chain mediated injury, right? And also amyloid can happen. Amyloid can indirectly cause renal damage, right? The first part is the myeloma kidney, or we use the term cast nephropathy. Please try to include this word. This is very, very important, which is something a pathologist will love in an exam sheet, called as cast nephropathy. Whenever there's an overproduction of the myeloma chains, especially light chains, The light chains will be absorbed by the proximal convoluted tubule and they'll form obstructing cast in the glomeruli. This is how a glomeruli is. So all the destroyed light chain is going to get obstructed here. If it's obstructed, can it cause damage? If you remember acute tubular necrosis, that's how it causes damage, right? So all this will be obstructed and this obstruction results in an acute kidney injury. You can correlate hematology with renal pathology. So once that happens, obviously it will cause renal failure. Obstruction related acute kidney injury which causes tubular damage and renal failure. This is one of the important cause of the renal failure. Fine. Okay. The light chain mediated a myeloma kidney or a cast nephropathy. Fine. Okay. Sometimes the light chain per se, okay, can be causing damage to the cells, especially if it escapes the tubules. There's a possibility some of the light chains might escape the tubule because not everything is there in the tubule. It can come from the blood vessels which is there in the kidney, right? That can cause interstitial fibrosis, interstitial inflammation, but there's a rare mechanism. Most of the common mechanism by which a myeloma's renal failure happens is cast nephropathy mediated by the light chain. Last but not the least, amyloids. You know that amyloid always deposits surrounding the blood vessels, right? So is there a possibility you have the beta platelet sheets AL amyloid type which deposits in the glomeruli, capillaries and the tubulointerstitial blood vessels again. So every blood vessel surrounding will be deposited with the amyloid. So over the period of time the blood supply reduces, which can definitely cause damage, right? Amyloidosis is one of the most common cause of non-diabetic, non-hypertensive nephrotic range proteinuria. Okay. So if a question comes on renal failure and amyloid, I want you to include three different things: direct damage via cast nephropathy due to light chain, and indirect damage of light chain into the interstitium without the cast nephropathy. Third one, amyloid and kidney, right? So there's a possibility this alone can come as a short note. Do remember that, fine? Okay. See, the reason why I used artificial intelligence here is it tells you how to present a simple diagram. This might not cost much of time, right? Simple. Draw a simple glomeruli. The light chains are getting filtered. Proximal tubule gets uptaked and it'll get obstructed here. Look at the beauty. It mixes with the TAM hospital proteins, forms the cast, obstructs everything. The moment it obstructs, obviously it will cause tubular damage, tubular injury, which results in AKI. Long term might result in chronic kidney disease as well, right? So a simple line diagram is enough. You need not be beautifully drawing diagram. Simple line diagram, simple scribbling will explain whatever is required for them. Fine. Okay. Now let's go to the last bit of the question. Can anyone explain this? Explain the principle if required, but what is the utility of serum protein electrophoresis and immunofixation in a myeloma patient? At least one finding I want you guys to answer. You guys can't keep quiet, right? You have an exam in 1 or 2 months. So tell me, what is the finding you will see in serum protein electrophoresis in myeloma? Then we'll see what is the use cases and what is immunofixation also. Not keeping quiet this time, right? Siddhi, Arya, Sarkar, Vijay Rekha, everyone who is there. Santosh sir, if you're not there, don't answer. Okay. So what is the use or what is the finding you see in serum protein electrophoresis? One clue. Immunoglobulin is a serum protein. That's a clue. So what will happen? I hope you remember that. Perfect. The M spike, right? So you remember the normal, right? Albumin, alpha 1, alpha 2, beta, gamma globulin. Normally, gamma globulin is the immunoglobulin, which is definitely smaller than the albumin. In case of myeloma, what happens? The albumin and also the gamma globulin, that's the immunoglobulin, becomes higher, right? So what do we see in serum protein electrophoresis? And please, it's written, they are asking about SPEP, right? So just maybe write a word about what is serum protein electrophoresis. Simple. I am going to take the serum of the patient, filter out the protein and do an electrophoretic mobility for the subcomponent separation, that is albumin and globulin separation. That is serum protein electrophoresis, right? So in a normal person, serum protein electrophoresis, we'll have albumin, same, alpha 1, alpha 2, beta, gamma globulin, right? The gamma globulin is your immunoglobulin. If you want, you can write that also. In case of myeloma, either the gamma globulin should be equal or more than albumin. Equal also is abnormal. because there's no way albumin can be equivalent to gamma globulin alone. In normal, albumin is 5.5, entire globulin is 3.5, right? So you can write that clearly. In myeloma, you have monoclonal or M spike. This signifies this increase in amounts of circulating immunoglobulin, which is produced by the neoplastic plasma cells. If normal or more than level of albumin signifies there is more amount of immunoglobulin, right? Now, can I say it myeloma, or is it possible in infarction rarely also? There's a possibility it can happen in infections also, right? Possible. Can happen, right? Not always, but can happen. That's why we have a second route, that is immunofixation. For every cancer, I have told you to remember one term, which is monoclonality. Cancers are monoclonal, which means a cancer can produce either IgG subtype of immunoglobulin or IgM, only that, not anything else, right? It cannot produce anything else. It can produce only one subtype of immunoglobulin, right? They have to be monoclonal, right? At the same time, I also want you to try this. Approximately 3% of the myeloma are non-secretory, which means they will lack M spike. Not everything will have M spike. Very less percentage might not have the M spike. Do put them as disclaimer as well, right? So second is, what is immunofixation? Fine. It will quantify, but immunofixation, so serum protein electrophoresis cannot identify the subtype of immunoglobulin. That is a problem for me because I need to tell monoclonality. If it is not there, I cannot identify that. How do I identify monoclonality? To identify the subtype, we do something called an immunofixation. It's the same electrophoresis. So what I'm going to do in immunofixation is, as the term says, immunoglobulin fixation. So what I'm going to do is, we are going to rerun the gamma globulin alone. You take the immunoglobulin alone and do an electrophoresis again. That's all. So when I do an immunoglobulin protein component alone electrophoresis, it will exactly tell me what chain it is, and both the heavy chain as well as the light chain, right? So an immunofixation looks like this, okay? G, A, M, D, and E, kappa and lambda for your light chains. Can anyone tell me what type of myeloma is this? If a question comes giving an image, you might have OSCE stations. They're giving you an image like this of an immunofixation. What do you interpret from this? Can I call it myeloma first? Yes, no. What is your answer? Can I call this multiple myeloma? Yes or no? With this image alone, can I call it multiple myeloma? The answer is actually no. With this image alone, I cannot call it, because this image says that G and kappa is there, but I don't know the quantity, no? So I want this also. If the quantity is high, plus it is monoclonal, I can call it multiple myeloma. If it's only monoclonal with normal quantity, it is just a specific infection, that's all, right? That's how it is. Generally, it will be neoplastic only, but there's always a caveat there, right? So this says that this type of myeloma is IgG kappa chain producing myeloma. So this immunoglobulin, this myeloma will produce only IgG and only kappa chain. It will not produce anything else. That's called immunofixation. There are two parts here. I'll zoom out a little bit. First, you do a serum protein electrophoresis, but the important thing is serum protein electrophoresis only quantifies the presence of monoclonal protein. It will not identify what subtype of immunoglobulin it is. It will say it is elevated, that's it. Then I do an immunofixation. Immunofixation pattern will exactly tell me what is elevated. The heavy chains and light chains, whatever it is, based on subtype, it will be there, right? And the most common type of myeloma is IgG subtype of myeloma. That's the most common type. And someone said flame cells. That's a clue. IgA myeloma in the microscopy might have a particular type of cells called as flame cells. These are just extra information. If you feel like, you can write about that, right? Okay, let me zoom out. That's a simple one essay question. Present like this, definitely they will not read further. It's neat, clean presentation, right? So the question was this: had a history. Along with the history, we had the diagnosis, the CRAP criteria, the bone marrow findings, why renal failure, and what is immunofixation. First, write the case sheet. Case sheet is how I want you to start every exam with, because this cannot go wrong. You are just redoing this in a point-wise manner. While writing, you will also be able to sometimes diagnose also, probably multiple myeloma. This is not required. I just told as an extra why there's Rouleaux in multiple myeloma. Then CRAP criteria. If time permits, 3 extra words slim, add it because this will add you extra marks for you. Fine. Then you know what is bone marrow. In bone marrow, I have two findings common for everything. Hypercellular marrow, suppression of the other hematopoiesis is common for almost every hematolymphoid malignancy. Bone marrow should have more than equal to 10, a minimum I should have more than equal to 10%. I can have normal, binucleate, multinucleate, nucleoli prominent, you have plasmablast and Dutcher, Russell bodies and Mott cells. All these variations I can have, right? Renal failure, light chain is the biggest problem. It can either cause cast nephropathy or it can cause non-cast nephropathy by damaging the interstitium in the tubule, and amyloidosis also can be a problem, right? And then your serum protein electrophoresis. Clear? Will you guys be able to present like this? Yes, no, maybe. I hope you'll be able to kindly use, if you're not good in your handwriting is not good, your presentation is not good, but you know the content. I want you to judicially use artificial intelligence. All these images are created by them. It's good if you do it in the right way, and please start at least know how to present, right? Then you will obviously present in the exam with obviously our own handwriting. That will not change. Fine. Okay, let's go next question. I'm going to do the same thing what I did previously. Can anyone read the question and tell me what do you think about this question? What is the next step? What will you do here? Moving outside of the screen, tell me what is the next step and what is the most probable diagnosis. 42-year-old, persistent change in bowel habits, significant unexplained weight loss, iron deficiency anemia, there's history of cancer in the family, though not explain what it is. What's the next step you will do and how will you approach this patient for arriving at the diagnosis? We have discussed the exact scenario in our classroom. So tell me what will be the next step you will do. Whatever comes to your mind, right or wrong, does not matter. Come on, anything. If you're wrong, doesn't matter at all. Altered bowel habits, significant weight loss, iron deficiency anemia. Will I think in terms of cancer? Because there's a history of cancer in the family and a bit of an elderly person, 42-year-old. With history, 42-year-old is definitely elderly, right? Great, Achinta. What will you do next? That's a good thing. You will suspect of a cancer because of unexplained weight loss. Can anyone tell me what cancer will be involved here? Which organ? Is it breast? Is it bone? Is it bone marrow? Is it leukemia? Which organ? Thinking of cancer is absolutely right. Colon biopsy, amazing. But before doing colon biopsy, an invasive test, should I do something before colon biopsy? Right? Thought process, same way case data sheet, elderly person, personal change bowel habits, unexplained weight loss, iron deficiency anemia. This is a very, very, very important clue. I've told this in an exam as well, right? When you are discussing as well in the classes. Elderly person, iron deficiency anemia, one of the important causes, occult blood in the stools, because I will lose little bit of blood every single day. If there's a proliferating growth in the colon, I have to first confirm that. I am suspecting colorectal malignancy. So what will I do next? You'll have to do occult blood in stool. Because obviously when I have an ulceroproliferative growth in the colon, it will bleed, right? Every single day, bleeding like 0.1, 0.2 ml. It will not change the stool color into red, but there'll be tiny spots of bleeding, right? So once that happens, over the period of time, the iron deficiency anemia will set in, right? If the occult blood in the stool is positive, then whatever Siddhi said is absolutely right. I have to do a colonoscopy plus a biopsy. That's the next step, right? That's what I'm going to do here, right? First, I do an occult blood in the stool. That's very, very important. Please do not bypass this and go here. You might be right. I'm not denying that, right? I'm not denying that. You might be right. It might be a cancer only, but it's still better to do a non-invasive test to be more confirmatory before putting a colonoscopy, because it's a painful invasive procedure, right? So no direct here. Do occult blood in stool, then do a colonic biopsy, right? Okay, let's assume that this patient turned out to be positive in the biopsy. We are identifying new malignant glands and we know it's a cancer. Fine. That's how the diagnosis is going to be confirmed here, right? So the polyp does not always happen in children. Polyps do happen in children, but polyps happen in middle-aged, older people as well, right? Now let's go to the second question here. Do anyone want to try here? Before going to it, I just want you to ask one simple question. I'm sure most of you will answer that. Can anyone tell me the syndrome in which microsatellite instability or MMR is abnormal? What is the syndrome's name? You know the answer for sure. What's the name of the syndrome where mismatch repair genes are abnormal? You know it. Starts with L. Heard about Lynch syndrome? Hereditary non-polyposis colon cancer? That's where we have, right? There are two big syndromes in colon cancer. One is FAP, other one is your HNPC or your Lynch syndrome, right? Perfect, Sarkar. Great. Fine. So the question is, what is the pathogenesis of your HNPC or what is the pathogenesis of mismatch repair genes, right? For that, again, whenever something abnormal is asked, try to answer with normal first, right? So what happens in normal microsatellite stable condition? Whenever there's a DNA replication, there's a possibility I can have an error. MMR, methyl mismatch repair, is just a DNA repair mechanism, which will, with the help of genes, MSH, MLH, just remember this, that should be more than enough. There are many other genes, MSH, MLH, and PMS2. These are genes which are important for you to remember this. With the help of these genes, the repair will be corrected. That's all. You might have read about this in detail in biochemistry. I'm just refreshing your knowledge of biochemistry, that's all. Whenever there's a DNA replication, automatically with the help of the genes, I'll be able to correct using methyl mismatch repairs. You must read about nucleotide exchange repair, methyl mismatch repair, base exchange repair, everything, right? So this is what happens normally. Now let's see what will happen if it is microsatellite unstable or a defect in MMR. So defective MMR, whenever there's an excess of cell division, see this cell division could be even normal because colon has villi, an epithelium which constantly every single day regenerates. It's a labile cell, right? It will automatically regenerate. So whenever there's a cell division, what happens here is during any cell division, if there is an error or mutation, error is nothing but a mutation. Once a mutation happens, because of any gene mutation, any defect in the MSH genes, MLH genes, or PMS2 gene, it need not be defect in all of them. Even one is enough for me, right? If one is gone also, the entire mechanism is going to fall back, right? Fall out, right? So this, you can't correct the errors. When you can't correct the errors over the period of time, I'll come to it. Is this me? One second. So over the period of time, it will start accumulating errors or accumulates mutations. This accumulation of mutations can result in neoplasm. Okay, I am not telling it to form cancer. Yes, it will form cancer. Before that, we have something called an adenoma. Only adenoma becomes a carcinoma. I am sure you know that, right? So this is what happens in case of an defective mismatch repair. And defective mismatch repair, they most commonly involve the right side of the colon. Okay, they involve most of the right side of colonic cancer. Fine. Okay, coming to question. See, presence of iron deficiency anemia. Soon after they'll tell you. Presence of iron deficiency anemia does not mostly indicate right side colonic cancer, but generally yes. I'll tell you why. Because you know that for a fact, a right side colonic cancer, right, or the proximal colon, the left side is the distal colon or the descending colon and sigmoid colon. Most of the right side colonic cancer will have ulceroproliferative growth. That's also a question in the subtype. We'll discuss about that later. Whenever there's an ulceroproliferative growth, there's more chance of bleeding. But you must have read that a left side colonic cancer forms a ring-like lesion. Will that bleed? It will also bleed. Not as much as right side colonic cancer. With the help of iron deficiency anemia alone, I cannot pinpoint it's a right side colonic cancer, but theoretically, there's more probability of it having a right side colonic cancer. Fine. Okay. This could be a reasoning why question. Why do I have right side colonic cancer in Lynch syndrome? The reason is simple. Right side colon, there is more cell division compared to the left side of colon. Because of the function, ascending colon still absorbs few nutrients, right? The descending colon and sigmoid just compacts the stool, that's all, right? So it has more division. Because of more division, there's more dependency on the mismatch repair. That's why you have the cancer. Any doubt, do let me know. Okay, now let's go to the next question. The next question is, discuss about FAP and its variants. Can anyone tell me what is the variance of FAP? What do you think is the variance of FAP? Any syndrome which comes to your mind, the variance of FAP. At least one syndrome, then we'll go to it. FAP is familial adenomatous polyposis. There are three important subvariants which I want you to remember. Whenever they talk about FAP, if there's an opportunity and if there's a time, tell how the gene mutation causes cancer also there, right? FAP is familial adenomatous polyposis. You know that. So in FAP, what we have is, you have a mutation, that's an inherited mutation, APC gene, which is there in chromosome 5, right? So what does APC gene does? APC gene normally will hold beta catenin. That's how normally it does. In case of APC mutation, that is loss of function mutation of APC, so this beta catenin is free, which goes to nucleus and it increases cell division. Okay, that's what happens in case of an mutated APC. That's a primary pathogenesis in your familial adenomatous polyposis, right? Then how do I diagnose FAP? Can anyone tell me the diagnostic criteria of FAP? If I find this in a question, I will call it an FAP. Anyone? If I find this in a question, in an MCQ, I will know it's an FAP. They are talking about FAP. If you see anywhere, a younger person, right, somewhere in 20s or 15, that age group, having more than 100 polyps, it's a very, very, very classical clue of FAP, right? So you should have more than 100 polyps in the intestine is classical of FAP. Family history will be present because an autosomal dominant disorder. Almost every cancer syndrome is autosomal dominant. You know that for a fact, right? More than 100 polyps, family history present. If you do a genetic analysis, APC will be mutated, classical for FAP, right? That is classical familial adenomatous polyposis. There are subdivisions, right? The first is, we have attenuated FAP. Okay, here also same mutation. If you want, you write this, otherwise just stop with this. APC beta catenin, APC gene mutation. But here I don't have 100. It's still more polyps, not only one. Up to 30 is fine, right? It's generally not 100. Fewer polyps, but can reach 100 also. Most of the time, it will be around 30 polyps. Like I said, FAP generally is picked up around 52nd to 3rd decade in that age group, right? 10 to 30 years is where we can pick it up. This presents later, around 50, 60 years. Okay. They also have a risk of cancer. Later diagnosis, attenuated, less severe form. So the cancer risk also is a little bit less compared to an FAP. Fine. Second is Gardner syndrome. It's also a variant of FAP. Here also I'll have polyps plus multiple things. I'll have multiple colorectal polyps. Along with that, osteomas, soft tissue, and dental abnormalities. I have a simple way to remember. Gardener, like a gardening person, has prick, hands will be abnormal, skin, bone will be affected. Polyp plus soft tissue skin is gardener. I remember turquoise plus turban. I don't know why it comes to my mind. Turcotte is equal to turbine for me, right? So head is involved, brain. CNS medulloblastomas, glioblastomas, think of Turcotte. Along with FAP, brain tumors, you want to think of Turcotte syndrome, right? Perfect. So these are the three variants of FAP. You have normal FAP and the variants of FAP as well, right? That is the next subdivision of the essay. Now let's go to the next one. Describe the classical adenoma-carcinoma sequence. See, here there's a very important twist which I want you to tell. There are two adenoma-carcinoma sequence. One for the FAP, APC beta-catenin related. That's the classical one. That is seen in syndromic as well as in sporadic cancers. The second is adenoma-carcinoma sequence for Lynch syndrome. That is totally different, not the traditional one. Because traditional will have adenomas, carcinomas, normal tubular adenomas. This will have something called as serrated adenoma, right? So this is a classical adenoma-carcinoma sequence. If this question comes, I want you to write whatever we read in FAP, APC beta-catenin pathway. If it's for methyl mismatch repair, that's a different adenoma-carcinoma sequence where from normal, it becomes an adenoma called as an serrated adenoma, and then you'll have multiple more mutations which will result in a carcinoma. That's a different one. It's not the routine one. That's something clarity which I want to tell you. Here it's about classical adenoma-carcinoma sequence. It's simple. Okay. So this is what I told you, right? The pathogenesis. Normal, it will hold and it will degrade the beta-catenin. It will not let it activate. If it's a loss of function mutation, beta-catenin accumulates, beta-catenin goes to nucleus, results in the proliferation of the cell. That's what normally happens in case of the APC beta-catenin mutation, right? This adenoma-carcinoma sequence accounts for both sporadic as well as syndromic. It's not just sporadic. The key pathway is APC beta-catenin. So what happens? Actually, you can draw this easily. See, not be artistically beautiful. A normal colon. Okay. The earliest event, I have a loss of function mutation of APC. Then it might be a small adenoma. Then I have an intermediate adenoma, little bit bigger. I have extra mutation KRAS. APC, beta-catenin, KRAS. Then I have SMAD2, SMAD4, loss of function. That's where TGF-beta pathway happens. Then I have TP53. Last but not least, always end with your telomerase activation. Telomerase activation is the one which pushes them into a cancer, right? So we have APC, beta-catenin, KRAS, SMAD or TGF and your telomerase, P53 and telomerase. There's a sequence which will convert a normal epithelium into a cancer. These diagrams are also easily possible for you. If you are hesitant in drawing a diagram, just write normal, okay? Then a tiny swelling. Then a tumor, then a tumor which can invade and go. Simple diagrams is also enough for you. But when you start drawing diagrams in an exam, it will definitely attract the examiner. If you're really gifted and you can draw a beautiful diagram, great. If not, a simple line diagram should be enough. Okay, great question. It's Mies. See, for me to brand attenuated FAP, I need a genetic testing because not the routine presentation, right? So once you do a genetic testing, I'll have the APC mutation. That's more than enough for me to tell. It's not MUTYH associated polyposis, and also the inheritance pattern differs a little bit. So family history somehow also will point me towards FAP, right? Okay, but good question. Okay, now let's come to the last part of this essay question. Give me the detail of the gross and the morphological difference between carcinomas of the proximal and the distal. That's the right side and the left sided colonic lesion. Like me asked, can I tell with iron deficiency anemia, it has a right side colonic cancer? To some extent, I told yes, possible, because right side colonic tumors and left side colonic tumors has a bit of difference, right? So what's the difference there? Okay. So adenocarcinomas generally I can have throughout the colon. I will not be able to say, okay, right side is more common than the left side. The proximal colon or the right side colon and the distal colon or the left side colon. I can equally divide in the transverse colon part, right? Generally, the proximal colon tumors are more exophytic masses, polypoidal masses like this. So there's a possibility it can automatically, since they are ulceroproliferative, it can automatically bleed from here. They rarely cause obstruction. This can be classical. Proximal colon cancers, circumferentially growing is difficult for them. They rarely cause cancers, but they can produce a mass lesion. On the other hand, distal colon cancers. Why I said I cannot ignore that iron deficiency anemia cannot happen here. This is also a growth, right? So there's a possibility it can bleed from here also. Okay. Distal colon are generally annual or circumferential lesions. Napkin ring is this part. If you have a napkin, if you go to big hotels, they'll have a tiny attachment. It looks like a napkin ring, right? Don't stop with that. Please write one more finding. The distal colon cancers in a barium study has a very, very classical appearance called as an apple core lesion. If it's possible, again, if you're good in drawing diagrams, do draw diagrams. Simple colon, this how the growth will be, right? So the entire, there's the wall or the growth here, right? And the barium will only pass through this area, which will form a shadow which looks like an apple core, right? A barium study will have a apple core lesion, and it will be napkin ring. Grossly, it's named as napkin ring because there's a constriction at the site of lesion, and both the sides you have a normal colon, and that's how it looks, right? And the probability of this presenting as IDA is slightly more theoretically, and this presents mostly as intestinal obstruction. Okay, so these are the two different changes in your right side and the left side colonic cancer. Satish, it can have BRAF mutation can definitely be positive, right? I'm not denying that. Fine. So BRAF mutations is one of the mutations which can be seen in the Adenoma-Carcinoma sequence. Not denying that at all, because when MMR goes away, the cancer can attract any number of mutations. One amongst them is BRAF. BRAF is also identified in microscopy. The only reason BRAF is emphasized amongst the other mutations is I have a targeted therapy for BRAF. That's the reason we emphasize on the BRAF. Doesn't mean that's the only mutation present. There are multiple and it's one among them. That's all. Fine. Okay. That's about this question. Again, a simple question. Please, again, I'm emphasizing, start with the data sheet. You cannot go wrong here. I'm just copy pasting what the clinical scenario tells. Do an occult blood, then do a biopsy. Don't jump to a biopsy, right? And then we saw normal and abnormal microsatellite instability. And then about the FAP and its variants. Then we saw about the adenoma-carcinoma sequence. The final thing is about the growth patterns of the cancer. Fine. So these are the two essay questions we wanted to discuss. And I have 5 reasoning why questions. I'll show the question. I want you guys to comment what is the reason for this, because reasoning why will test actually your in-depth understanding, which is very much essential for you for the NEET PG and NACD exams, right? Okay, this is the first question. Can anyone tell me what's the answer? It's me, I'll answer your question. Just give me some time. We'll complete this and answer the question. Anyone, what's the answer? It's a simple one-line answer. Why are patients with sickle cell anemia more susceptible to encapsulated bacteria? Tell me what's the answer. It's a simple one. I am sure you know the answer. Come on, it's not difficult to think for such a long time. Great, yeah. It's due to autosplenectomy, that's all, right? Simple. Sickle cell anemia, there's a possibility you will have the vaso-occlusive crisis. Because of the vaso-occlusive crisis, there's a possibility for you to have autosplenectomy. Because of autosplenectomy, the spleen's function goes away. There's an increased risk of infections. Okay. See, this increases your critical thinking, which is very, very, very important for a practicing doctor. At the same time, this time FMG exam, an amazing exam. It went purely clinical, though it's not the right exam to ask for an FMG. For a NEET PG or an INACD, it's a very good question paper. It is on analytical skills rather than memorizing the genes and everything, right? Sickle cell anemia can have vaso-occlusive crisis, autosplenectomy, increased risk of cancer. Your CBME is made for that. I think the exam pattern slowly will change, integrating all the important things, right? It's me the see the reason why it's see here. imagine this is what happens to the left-sided or the distal colon cancer, right? So here, the peristalsis will be affected, right? Because in both the sides, I'm having constriction like a ring. So when the peristalsis is affected, there's a possibility the feces start accumulating here because I need a proper peristalsis for the feces to go, right? Starts accumulating. After a certain amount of time, the weight per se can push through the narrow opening and can go away. That is the reason there's an alteration in the bowel habit, right? So imagine it's like a hourglass. You put solids on the top of the hourglass, not moving, right? Only the tiny part moves. So I'll have altered bowel habits more on a left-sided colonic tumor. Here, altered bowel habits will not happen because this much space is there, right? It'll definitely go outside. Irrespective of the size, see, both of them at the end stage, when everything is obstructed, I'll have altered bowel habits, right? And here, why more is this almost always has an ulceroproliferative mass. Okay, this is more of an infiltrative lesion. It infiltrates surrounding it. That's why that happens. Fine. Okay. Done. Perfect. The next question. Next reasoning why question. Why is there thrombosis in case of a nephrotic syndrome patient? Increased risk of thrombosis. Why is there thrombosis in case of a nephrotic syndrome patient? You know the answer. The only one word is required here. If you know the word, you know the answer. The thing about reasoning why is, if you know it. If you don't know, it's tough to recollect it. The reason for thrombosis? Simple. Nephrotic syndrome loses protein. Nephrotic syndrome grade C. It also loses antithrombin 3. It loses fat, causes hyperlipidemia. It loses protein, results in edema, albumin, right? It loses antithrombin 3. Since antithrombin 3 is lost in case of nephrotic syndrome in urine, that results in increased risk of thrombosis. I'll add one more reasoning why question here. Nephrotic syndrome, also there is a loss in transferrin, right? So that they might have iron refractory, iron deficiency anemia also. Okay. So here they may also lose transferrin because these are something which are not very well emphasized. We'll always emphasize on albumin and we'll say edema is there, right? They also lose transferrin. So there's a possibility they'll have iron refractory iron deficiency anemia. Because if transferrin is lost, if I'm going to give iron tablets, who will go and take it to the bone marrow? They won't, right? So these two also will be lost. Though not in every case, it's significant enough, but if it's significant, these two will be the symptoms of the patients. Do you remember? Okay. The next one. The simple one. I'm sure most of you will answer this. Why do patients with vitamin B12 deficiency develop neurological symptoms? Anything which comes to your mind? Why do patients with vitamin B12 have neurological symptoms? This is a simple one because B12 is very, very important for sphingomyelin or myelin synthesis. So once myelin is less, obviously demyelination happens, which results in that. Fine. Okay. That's the reason patients with B12 deficiency will develop neurological symptom. And there's a very important differentiating factor between B12 and folate deficiency because both will cause megaloblastic anemia, but B12 deficiency will have neurological symptom. Folate deficiency will not have neurological symptom, right? Perfect. The next question. Why do patients with DIC also have widespread why they have bleeding despite widespread thrombosis? Why do patients with DIC have bleeding despite widespread thrombosis, right? The only one word is enough for it to know the answer. That's the other name for DIC, which is DIC is also called as an consumption coagulopathy. Okay, it's a consumption coagulopathy, right? So the widespread thrombus is a starting point, right? So once there's a widespread thrombus, this thrombus per se, I'm going to have hundreds of thrombus in the tiny microcirculations in the body, right? This will consume platelets. consume the clotting factors. Once the consumption of clotting factors and platelets goes away, is consumed, automatically it will result in bleeding. The patient bleeds. And I want to add one more important EPG PYQ here. So what test you will do in order to know the patient is in bleeding phase or the patient is in thrombotic phase? This is a very important test. The bleeding phase will be determined by the amount of fibrinogen in the blood. The fibrinogen levels in the blood is kind of a marker for me to tell, okay, the person is going to be in the bleeding phase. This is very, very important, especially in the treatment. I don't know which side of the SWOT the person is, right? So if the person is having clot, I have to give anticoagulants. If the person is bleeding, I have to give platelets and clotting factors. So I need to know what to treat. For that, one of the most important things is fibrinogen. If the fibrinogen levels are less, yes, definitely the patient is tipping more towards the bleeding. I'll treat accordingly. If the fibrinogen levels are normal, I'll look at this possibly in the clotting part, right? Okay. Next question. This will definitely come in the Viva. If they're not asked you in the second internal Viva, they might ask you in the final exam Viva for sure. See, the D dimer is for me the thrombus part and bleeding the fibrinogen part. Why is reticulocyte count not increased to the degree of anemia and thalassemia? It's a very important question, can definitely come in the Viva. Anyone? Why is reticulocyte count not increased to the degree of anemia? It is increased, I'm not denying. It will border around 2-3 maximum. Why it's not increased to the degree of anemia? Because in Thal major, the anemia will be around 5-6 gram percentage. Grade it's me. It's about ineffective erythropoiesis. This word is very, very important. They might ask you and you should know it without fail. It's ineffective erythropoiesis. Okay. So what does it mean? It's simple. Whenever I have hemolytic anemia, my bone marrow will respond to it in the intention to correct the anemia. That's all, right? For example, in Thal major, okay, I have hemoglobin, let's say in the range of 7 gram percentage. Fine. Here, the bone marrow will undergo hyperplasia. Actually, what should happen? It should undergo so much hyperplasia in order to make the 7, 12 or 13. That much how 100 or 200% it should perform. Only then I can correct, right? It will undergo hyperplasia. But the problem here is the excess accumulation of alpha chains will go and destroy the blast inside the bone marrow. Bone marrow will divide, but like exactly you pointed out, I'll have an intramedullary destruction of blast. Which means in the bone marrow, the blasts are going to be destroyed. Let's assume that 50% is gone. Still, I cannot correct the anemia, right? So, intramedullary destruction of blast, so the anemia will not be corrected. And it goes into a vicious cycle. Again, it'll end here, it go here. Not just the anemia is not corrected, at the same time, the RBCs which is coming out, that's a reticulocyte, right? Not many RBCs, not many retics will reach to the place, right? Not many blasts reach to the retic stage. Since not many blasts reach to the retic stage, I will not have increase in reticulocyte count, as simple as that. They will look for this word. This word will get you the enough mark, that's more than enough. But the reason is that because of more and more destruction, not many blasts will reach the retic stage and the reticulocyte will not come outside and it will not correct the anemia, right? Okay, perfect. That also could be a reasoning why question. Why do I have splenomegaly? Answer is same. Because thalassemia is not an extravascular hemolysis, right? It's an intramedullary destruction. It's not an extravascular hemolysis. The reason why splenomegaly is also ineffective erythropoiesis because spleen, bone marrow is failing. So spleen as well as liver will have extramedullary hematopoiesis in order to support the failing bone marrow, right? They also cannot do anything because the problem is not in the bone marrow, it's in the blast. Spleen's blast also will be ineffective only. Liver's blast also will be ineffective only because I have a mutation in the blast. This both could be a question which can come in an exam. Do remember that. Fine. Okay. That's it for today. We saw 2 essay questions and we had 5 reasoning by questions. I'll put this in the WhatsApp group for you guys and we'll keep discussing. I'll also add today's revision sheet on genetics and immunology. So we'll slow and steadily we'll complete it. We'll add a little bit more reasoning by questions in order to kind of stimulate your thinking process, thought process, which will help the entire country in long term. Fine. Any doubts? Do let me know. Otherwise, we're done for the day. No doubts? Okay, it's me. The answer is simple. It's there in your question, right? See, for me, in case of an beta thalassemia trait, okay, one, the destruction is not that great, right? To start with. That's why it is hemoglobin is in the level of 10 to 12 gram percentage. So the destruction is not that great. My intramedullary blast destruction will not be that much. So it's not much of a problem. Plus, I need not replicate like 100, 200% of my effort because already it's in the range of 10 to 12 approximately. So here, even if I can increase to, let's say 13, that's enough for me, right? So I'm not losing much. So I need not first replace much. Second, this destruction is not going to be that great in case of a thal trait because it's a minor pathogenesis. That's the reason I'm reaching 10 to 12 itself, right? So still they can escape, still good amount of retic can come outside. Ping me here. Okay. Ping me here. Unfortunately, there'll be a WhatsApp AI which will be replying you. I'll definitely get back to you, Achintya. Fine. Clear, it's me. Okay. See you guys. See you in the next class. We'll discuss a little bit more in the same way till your exams before Farai starts. Fine. Thank you guys. Thank you for your time. Most welcome. Satish, there are drugs called as there are 2 drugs in the market: vemurafenib, darafenib. See, if you are asking for a real life patient, I would say leave it to the oncologist because there are lots of parameters for me to before giving the treatment. Okay, just because there's a BRAF mutation, I'm not going to give this, and the patient will not have a miraculous recovery. There are lots of parameters, but for theoretical purpose, these 2 are the anti-BRAF inhibitors which will help. Okay.